to the third episode of Retina Chats. I'm Mohammed Ghunaim, and with me Dr. Mustafa Manhal.
Hello.
So today Dr. Mustafa will present his case. So tell us more about this case.
This is a case of a 54-year-old diabetic patient that was under supervision after doing laser therapy for PDR, and the vision was stable between 0.5 to 0.6. Then he presented with a sudden diminution of vision, and on examination and doing the OCT, we found that there is a recent full thickness macular hole. So the patient was planned for a vitrectomy for the full thickness macular hole and doing an ILM flap. But the challenge in this case was that the difficulty of doing the PVD wave and to propagate this wave so we can clear up the macula and we can initiate the ILM flap. So in the beginning, we tried to start the wave or to start the PVD using the cutter as usual, but it was very difficult. Then we started to use the end gripping forceps to peel
This
and
is a
clean.
special end gripping forceps, right? It has serrated edges, I think.
Yes, because it's a serrated, yes, it's from Romix and it has a very good grip. So it holds well, and the grip is very helpful, especially in this fibrotic.
Yeah, it helps in
features.
the thin layers of posterior hyaloid, especially in diabetics.
Yes.
If we use the regular ILM forceps, it may just tear up the membrane.
It shreds, yes.
Yes. Basically the case has a tight posterior hyaloid all over the retinal surface. So
Yes, and
we have to clear
multiple-
this up before accessing the ILM.
And there are multiple epicenters, as we can see. So the message here is that we go like a baby steps in PVD induction. So whenever there is a wave that can propagate without doing a traction over the retina, so we will propagate. And when we find these attachments, so we have to do it like a unimanual dissection for this membrane.
So whenever you find a tight
plane,
attachment,
yeah,
you
stop.
stop and cut. When you find that there is a plane of cleavage, you
propagate this
propagate the wave. Yes.
Yeah. And keep doing this as long as there is no tears, and definitely doing a tear in this step will be a very
difficult situation. Yeah,
yes.
It may terminate the surgery because, and you wouldn't complete doing the
flap,
the ILM
which
flap,
is the main, which is the main target for this for this surgery. Yes.
Okay.
So I'm trying to complete the PVD and doing the whole job in this step, and but I'm trying to weigh up the risk and benefit, not to compromise the macula, to avoid any macular detachment before doing the flap.
Yeah, there's some fluid, subretinal fluid appearing here.
Yes.
Yeah. Okay, so you stain the ILM here first.
Yes, this is why I stopped at this step and I shifted to the macular lens and starting to do the ILM flap, just to be sure that I can do it when the macula is still attached, because if it is detached for any reason because of traction or iatrogenic breaks, this step would be very, very difficult, and I may need to add a PFCL to just stabilize the macula. So as we can see in this step, we can achieve it nicely and do the temporal flap. And usually I extended a little bit, like not just a temporal one, I'm extended like 270, and then I started to complete the PVD wave.
Okay. You did it very nice. Would you consider bimanual in this case by any means, or just continue with the baby steps and the unimanual dissection?
What goes in my hands better, that I go with unimanual, and I prefer using the cutter between doing a dissection and pulling, then alternating with cutting, then doing this with a scissor and using a forceps.
I agree with you, because I believe that bimanual surgery is best if the retina is totally detached. Then it can be easier and more safe.
Yeah, or if there is a broad attachment, so all of them are tiny epicenters, so you just remove this attachment, then you have a very clean plane of cleavage, then you can go. So in this one, this was a braid attachment, so I have to segment this membrane and then I shave it from the surface of the retina. And in this case, I was using the 23 gauge.
Two iatrogenic
these two iatrogenic breaks, because at the end of the surgery, when you are sure of yourself that everything is going well, so you are in a hurry up. And this is a very good advice for myself, at least, that when you feel that the job is done, you have to stop and weigh everything. And for me, the cause of this hydrogenic breaks, that this is an ischemic retina, and I should have shifted my hands and go
Yes,
with the cutter
exactly.
from the left side so I can dissect
I
under this
always do
membrane.
the iatrogenic breaks in the same way,
Yeah, yeah.
on my right hand, and not shifting left hand. So it happens to me all the time, and every time I have to remind myself to shift my hands, but I sometimes just
But believe
forget
me,
about it.
as our professors told us before, that when you feel that you are confident and the surgery are almost done, you are going to have this mistake. So
Yes.
when you feel that you are done with your surgery, you did the eye lamp flap and everything is going okay, just stop and do everything cautiously, because you are going to do these breaks.
Yes, exactly. I've seen you didn't do any endodiathermy to the bleeding points. Do you usually use diathermy in the in?
No, I rarely use that diathermy, except only in rheumatogenic breaks to highlight the break, or in uncontrollable bleeding during the surgery. And this is not the case in here in our
I
surgery.
have to disagree with you. I like using diathermy in these cases. I also try to decrease the bottle height or decrease the intraocular pressure to check if there is any bleeding points, and diathermize them as much as possible, because I hate having post vitrectomy hemorrhage, and in my hands this decreased the rate of post vitrectomy hemorrhage.
So the idea of lowering the IOP at the end of the surgery to see any leaking or oozing points is a very good advice, and I do this. But using the diathermy is not 100% guarantee that you are
Yes,
not
of
going to
course.
have.
It just
So
decreases the rate. There
yeah,
is always a rate of post-vitrectomy
I
hemorrhage,
don't use it that much.
but I found that if the more I use it, there is a less rate of post-vitrectomy hemorrhage. And I diathermize the large vessels, not the tiny ones, the large ones that. And as you said, of course, if I have massive hemorrhage or a pulsatile hemorrhage, I use it. But even the larger ones, I have a lower threshold to using
Let me
diathermy.
ask you two questions.
Okay.
Do you intend to remove every single membrane as the one I left in the
Um,
temporal part?
I would, in this case, I would try to shave it as much as possible without causing more harm. But I see that it went well with you, and the post-operative image is very nice.
And the second question, which tamponade would you
Yeah,
have
here I
used?
would use gas.
Gas,
Yeah,
no
yeah.
silicon, because that there is a break and there is a residual membrane.
If
So
the membrane is connected to the periphery and there is a broad adhesion, then I would leave silicone. This is an end step, and I know that this surgery is not is not going well, and this eye is not having a good prognosis. But if there is a small traction and it's not connected to anything else, 360 degrees, even if it's beside a break, I would leave gas and leave it, no problem. But if there's a big sheet of posterior hyaloid that is reaching to the periphery, and this and I couldn't complete the PVD as usual, then I would leave silicon, and I wouldn't consider this a real success, and this eye wouldn't go very well in my hands.
and would you also believe if doing this surgery and removing the fibrotic membrane and the PVD, will it be sufficient without doing the eye lamp flap to close the hole?
No, no. Once there is a full thickness macular hole, you have to address the eye lamp.
Okay.
Removing the posterior hyaloid or removing tractions wouldn't repair this. It could repair lamellar holes, could repair some corrugations, but once there is a full thickness macular hole, it's best to do an eye lamp flap. There's a post-operative OCT. Yeah,
Yes, this is 2 months after the surgery. We can see that the macular hole is closing well, with the residual outer retinal layer still.
fluid. Yeah.
Yeah, this is not fluid. It's just a reconstruction step for the outer retinal layer.
Okay.
So the vision of this patient is improved from counting finger from 4 meters to zero point 0.3 in this step, and he's under follow-up now. And this patient is phakic, and he doesn't get any cataract or whether nuclear protrusive subcapsular or anything.
Okay, so is this your usual experience in full thickness macular holes in diabetics? the improvement in vision?
Yes, because especially if this patient is controlled regarding the glycemic level, and if the retina is already stable with a previous laser, which by increase the difficulty during the surgery, because laser increases the adhesion of the vitreous to the retina, and this may induces a lot of iatrogenic breaks. So, despite that the laser is a very protective tool for PDR and for those patients, it may
Make surgery difficult.
yes,
Okay, I believe this patient is your patient. You did the PRP and you're following him up. So I believe he noticed the macular hole and came to you directly. So this is why I believe that he improved in vision. There wasn't a long time of he didn't neglect the macular hole.
yes,
But if there's a neglected macular hole in a diabetic, I believe it carries a poorer prognosis than normal patients or non-diabetic patients having macular full thickness macular hole. So I believe since this is your patient and he's keen on his follow-ups, you had a good outcome. Okay, so this concludes our case. Thank you very much for watching. Stay tuned for the next one.
thank you.